You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for professionals. I'm Dr. Ken Miller. I'm a medical oncologist, hematologist, and an LLS volunteer. And I want to thank all of you so much for joining us for this episode. Today, we're going to be discussing pediatric blood cancers, from early detection to diagnosis and timely referrals and treatment updates. We're also going to discuss resources to support both healthcare professionals and families. We're delighted to join by Dr. Jeffrey McGee, who is the Elizabeth H. and James S. McDonald III Professor of Pediatric Hematology and Oncology and Director of the McDonald Pediatric Cancer Center at the Washington University School of Medicine in St. Louis. Jeff, thanks for joining us.
Oh, thank you so much for having me.
I'd love to talk about two things. One is a little bit about just the experience of being a pediatric hematologist and an oncologist. And then the second is for generalists and in adult hematology and oncology. Love to find out some of the new advances in pediatric blood cancers. So let me ask you about the practice of pediatric oncology. Very often when I tell just regular people that I'm an oncologist, they say to me, how do you do that? With a little bit of doubt about, geez, how could I practice this and live this? And so I actually want to ask you the same thing. What is your day-to-day experience like in your work? And if someone asked you, how do you do this? What would you say?
Right. That's a great question. It's one that I do get frequently. When I'm talking about my job, whether it's to prospective fellows or to other colleagues or to parents of children who are sick, or to just friends in the community, I come back to a few key principles. First of all, this is a job that I feel really privileged to do because what we're working on is existential for people. So when we're taking care of children with cancer, obviously this is probably the seminal event in both their life and their parents' life. And so being able to be the person who can walk into that room and have a plan is, to me, a really great experience every time it happens. Even though you are confronting these families on the worst days of their lives, I find it really rewarding to be the person who is coming in with a skill set that can be helpful. I also find that one of the things I really love about the job is that it operates right at the interface between the science and the professional practice of medicine. I feel like this is a field that hasn't crested, right? We still have a lot to learn for all of the new tools that we've been able to bring to bear on these cancers. We still have an awful lot to learn, and it drives from the molecular biology and it drives from the cell biology that we're doing at the bench and in our clinical trials as well to really learn more and advance the field. And I, again, find that very challenging, very rewarding. And then with regards to pediatrics, specifically, I really like the patient population. The ages span from birth all the way to the early 20s at least. And so you're talking about people at very different formative phases of their lives. When you're talking about young children, there's the challenge of helping them understand what's going on and coaching them through it at an age when they really can't appreciate why they have to be in the hospital. When you're talking about teenagers, you're talking about people who've had their lives interrupted. They're not going to prom. They're not going and doing things that they'd envisioned for their teenage years and that their peers really get to experience. And I find that diversity of experience to be very rewarding. And I also really like explaining to parents, the rationale behind what we're doing and trying to bring some level of comfort that comes with being competent and being able to understand the science of the disease as well. And then I think finally is how do you do this? Is that tough? When I get that question, I would say that a lot of our patients do well. And this is an area of oncology where we have made huge advances, even since I was a fellow, such that the tools that we can wield are just, I couldn't have even imagined them when I started, and that was only 15 years ago. So I think this is a great field in that regard too.
When people ask me the same thing, it's everything you said is pretty much what I say too. What a privilege we have to do the work that we do. So thank you. Thanks for sharing that.
You're welcome.
I think we each share good news. Sometimes we share bad news. And I wanted to ask you, what is day one like when you walk in to meet a new family and patient?
That's a great question. So, when I'm meeting a new patient and a new family, I think there's a few goals that we need to address. So, one of the first things I want to do is just sort of take the temperature of the room and understand where the family's at. So, you almost need to start off listening before you can start off talking. When you're meeting families, they are at different emotional states. They have different understandings of what the diagnosis could mean. Some of them haven't been informed fully. Some of them have different levels of understanding just of medicine. And so you really want to know where people are at so that you can then engage in a dialogue that's appropriate for where they're at. And then you also want to be able to start laying the groundwork for what's going to come. So the second goal is actually just to start helping them anticipate what the first few days will be like, because that diagnostic workup for families is a bit like drinking from a fire hose. There's a lot coming at them. There are a lot of tests often scheduled, and you really want them to understand why. And then the next goal is to help them understand that they're in good hands. Yes, this is a life-threatening diagnosis, but it's also a diagnosis that we have a lot of experience managing and coping with. And there is a lot of science that we can bring to bear on this problem, and our outcomes are often good. I never lie to families. So if this is a leukemia that has a grim prognosis, or if there are reasons to be concerned, do you feel like it's compelled to at least deliver that bad news, not in a way that says that we don't have tools in the toolbox, but at the same time, help them understand what the landscape really is. And that's something that's just come with experience. And then the final thing, this is one thing that's maybe sometimes overlooked in non-academic practices, is that it is, I think, important for families to understand that they could potentially benefit from clinical trials. And so I do spend a little bit of time when we do have relevant trials going through that with them as well, if they're in an emotional position to engage in those discussions as well.
Thank you. So I'd love to go on and talk about some of the science in pediatric blood cancers and some of the advances. I wanted to ask you, even at a 60,000-foot level, why certain cancers? I mean, this is a question parents probably ask, but why? And why in particular ALL develops in children more than AML, more than very rare would be myeloma and things like that. But what's your view of the biology?
That is one of the fundamental questions in our field. Is, if I could rephrase it for you, first of all,
Sure.
why do
Yeah.
children get cancer at all? When you think about the primary causes of cancer, the greatest risk factor is age, and the next greatest risk factors are environmental exposures such as smoking. And children don't have that as underlying causes of their cancer. So we want to understand, what is it that's unique about childhood and childhood blood development that's responsible for contributing to the types of cancers that they get. We've learned a lot in that regard. So with regards to acute lymphoblastic leukemias, for providers, this is the leukemias that evolve out of lymphocytes, the adaptive immunity, and presents as either B-cell lymphoblastic leukemias or T-cell lymphoblastic leukemias. I think it's probably has a lot to do with there's formative events in immune development during those first few years of life in terms of exposure to new pathogens, massive expansion of the B cell and T cell populations that do contribute to propensity to develop leukemias. But there are some things we still don't understand, because even within patients who get B cell leukemias, there's different mutations, say in 2-year-olds, compared to the types of mutations we see causing B cell leukemias in adolescents or young adults. And so I don't think we fully appreciate why these differences occur, other than to say that part of the work in my own lab, focusing more on myeloid leukemias, has tried to understand it as can the cell actually respond to that mutation? So what we found in some of the work ongoing in my lab is that certain mutations really only can activate the programs that lead to malignancy if they occur at a specific age. And so the propensity to develop a specific type of leukemia is intimately tied with the normal processes that regulate blood development.
Interesting. What does layered leukemogenicity mean?
Right. So that term plays on a more general term called layered immunity.
Yes.
And the term layered immunity talks about the development, again, of the immune system. So there are certain immune cells that only develop out of fetal blood progenitors. And so if a fetal blood stem cell can only give rise to certain types of B and T cells and so forth. And then as the immune system develops, then you get neonatal or juvenile stem cells, blood forming stem cells that are now giving rise to different types of immune cells. And so the whole immune system is changing through the course of human development, and the types of immune output are changing. So what we're alluding to when we talk about layered leukemogenicity is that we're demonstrating how those changes in immune development that occur naturally with age are again changing the types of leukemias that will form. And we think that this accounts for the changing spectrum of blood cancers that we get throughout life, such that children get certain types of myeloid leukemias and certain types of lymphoid leukemias early in life, and different types in adolescence that are still different than what we see in adults.
Thank you. It's interesting because the adult population, we look at, sort of markers, molecular markers, targetable, drivers, et cetera, but typically don't have that same perspective, based on a mature immune system. So it's very interesting to hear some of the differences. Let's focus for a few minutes on childhood ALL. Looking back on your career and even the last 30 years, such progress. What were the key factors that made such a difference? And what is the prognosis now based on all that progress?
I'm going to answer the last part of your question first and say right now the prognosis is exceptionally good for most patients with B-cell lymphoblastic leukemias. And that has been the product of 40 years worth of research, maybe more. So back in the 1960s and 1970s, a diagnosis of B lymphoblastic leukemia would have been near death sentence. Survival was only around 10 to 20% overall for patients back in those decades. And then with every successive decade, the survival has advanced. So the initial advances just came from recognition that chemotherapy can treat cancer. So this is one of the first cancers that was actually treated with chemotherapy. We saw instant improvement in survival. We meaning my predecessors. I was not even born when some of that was started. But then what happened through the work of what are called cooperative groups. So I think Pediatrics in particular has a long-standing history of cooperative research across institutions. And the reason for that is that the cancers are relatively less common. And so to be able to run a well-powered clinical trial, you need institutions to collaborate. And so the current iteration of that is called the Children's Oncology Group, as well as there's some other European and cooperative groups as well. What the cooperative groups did is they designed clinical trials that would start implementing new iterations of chemotherapy. So, for example, we now in treating acute lymphoblastic leukemia, we have many different cycles. We have one that's called induction, and then there's a consolidation, and so on and so forth. It ends up being about 2 to 3 years of therapy. But what we found is that by adding or taking away cycles, we could improve outcomes sort of empirically, right, by modifying a bit. Then superimposed on that, we got much better at what's called risk stratification. So we learned who needed more chemotherapy and who needed less chemotherapy. And so that improved outcomes because the patients who needed more chemotherapy were getting it. And then the patients who didn't need as much chemotherapy were not being subject to the toxicities associated with that. And that came from understanding the genetics of the leukemia first by looking at what are called cytogenetics, like just what are the chromosomes that are broken, as well as a technique called minimal residual disease or MRD. Basically, the concept here is that if the cancer responds very well to initial chemotherapy, it's likely to continue to respond well to chemotherapy. And so the lower the residual disease after one cycle of chemotherapy, the better the outcomes. So we could actually basically determine how much chemo we needed to give to patients to improve their outcomes, and that led to improvements. Then, I would say in the 2000s, we started introducing a lot more molecular techniques that have shaped our ability to treat. So, for example, we were able to identify patients who had a subtype called Philadelphia-like. So these are patients who had biology that's similar to a high-risk type of ALL called BCR-ABL or Philadelphia positive leukemias. Those patients historically had worse outcomes, but potentially benefit from specific drugs that block the product of that mutation called the Abl kinase. And we could identify patients who didn't have that specific mutation, but still had biology that resembled it. And through additional science, we're able to identify the underlying molecular causes of that. And so now those patients are again directed towards more therapy or alternative therapies. And then finally, we've also had now integration of immune therapies into our regimens. So I'm sure a lot of people have heard of CAR T cells, which are basically immune cells engineered to target and kill B cell lymphoblastic leukemia cells. And they've been often very effective in certain cases, especially in cancers that are resistant to chemotherapy. So you're basically bringing an alternative tool that doesn't simply require chemotherapy or some of those chemotherapy sensitive mechanisms to kill the leukemia. Now you're using the immune system to kill the leukemia. And then there's a drug called blinatumomab that has found its way into our standard of care regimens because the most recent trial that used blinatumomab showed 98% event-free survival for standard risk patients and around 90% event-free survival for patients even with high-risk disease. When you already have pretty good outcomes, pushing the needle even that much further is really remarkable. And so our standard of care has really, really improved for these patients. I know that's a long answer to your question, but there's been a lot that's gone into it. So
Amazing. I've been nodding my head saying, wow, because, geez, I wish we had that with adults, and maybe one day we would. So it sounds like, again, the initial therapies have been refined. One thing I did want to ask, I know there's obviously been great respect for the issue of cancer survivorship. So a few questions. There's apparently 16 million adult total cancer survivors in the United States. How many survivors of childhood cancer?
Well, so let me reframe that because I think the number is going to continue to go up as our survivorship improves, right? There's about 4,000 new cases of leukemia every year in the United States, and about 2/3 of those are going to be acute lymphoblastic leukemia. And now about 90 to 98% of our patients are going to survive those leukemias because we have good tools for that. And then even with AML, overall cure rates are in the 65 to 70%. So if you think about it, how many new patients every year will become survivors of childhood cancer? I would expect for just leukemias alone, it's going to be 3,500 new survivors of leukemia in the United States.
In terms of de-escalating therapy, which I know has been an interest, taking things off the table, have you found that there's a limit to that, that there's a threshold you can't go below?
I think to answer that, we need to break it down into specific types of cancer because there are still some where we're trying to dose escalate, and there are others where some of the newer therapies that we can bring to bear can really help. So, if we again look at B cell lymphoblastic leukemias, I think that's one of the new goals for the clinical trials that haven't been developed through Children's Oncology Group is to figure out what you can take away. Can we take away part of a phase that's called delayed intensification? Could we take away some of the maintenance cycles that extend this out to 2 to 3 years? And I think those are still trials that are under construction, but I imagine we'll be able to find some steps where we can take away therapy. I will say, though, that there are areas where we've proven that we can de-escalate. So if we go back to those high-risk leukemias that are called Philadelphia chromosome-positive leukemias, they have a specific mutation called a BCR-ABL mutation. And when I trained, those patients went to bone marrow transplants always because it was considered a high-risk malignancy. But now we have inhibitors of that Abl kinase. It started with a drug called imatinib. Now there's dasatinib and some other newer generation inhibitors. And once they were superimposed on chemotherapy regimens, we found that those patients didn't need to go to bone marrow transplant, that the outcomes were just as good as long as you used the inhibitors. And now the most recent trials will probably show that this is beneficial. We can even reduce some of the intense chemotherapy that those patients were getting and make it a little bit more like we would give other patients with acute lymphoblastic leukemia. There's other types of leukemias. So there's a specific subtype of acute myeloid leukemia called APML, or acute promyelocytic leukemia. And again, those patients used to receive a lot of chemotherapy, particularly a type of chemo called idarubicin, which can have side effects on the heart. And the most recent trial on that incorporated two agents, one called arsenic trioxide and another one called ATRA. And for the majority of patients, they can be treated with those two agents alone without any chemotherapy whatsoever, with survival that again pushes 100%. For certain types of lymphomas called Hodgkin's lymphoma, we're finding that there are drugs called PD-1 inhibitors that again can allow us to reduce the amount of chemotherapy that patients are getting. And these things are proven now. And so I think what you see is that there's an advance in the drugs that are available. We put them on the backbones of the trials. If they prove to be effective, we start peeling back some of the chemo or radiation. And I think that it's iterative over time.
Thank you. Let's focus for a few minutes on childhood AML, which I know is one of your great interests. How common is it? What does upfront therapy now look like compared to what it may have been in the past? And I know you've written some about primary chemo resistance. I'd like to hear more about that.
Yeah. So AML is, I would say, one of the diagnoses that's still a little frustrating because we haven't made nearly as much progress as one would hope. It certainly has paled in comparison to the B-cell acute lymphoblastic leukemias. It makes up about 15 to 20% of all pediatric leukemias. So again, of those 4,000 new diagnoses a year, probably about 1,000 of them will be AML. And when I think about AML, I think about it as not just one disease, but often about 20 different diseases because the underlying mutations really dictate prognosis. There are some that we consider favorable that will, again, have about chances of it going away and staying away around 70%. And then there's some that my lab focuses on, particularly like NUP98 rearranged leukemias and some others that are very high risk. And survival still is in the 20 to 30% 3-year overall survival. Those are the patients also who will be very resistant to initial cycles of chemotherapy. I think one of the more frustrating aspects of AML therapy is that it really hasn't changed in about 40 years. It's still a backbone of cytarabine and an anthracycline. And our most recent clinical trial that closed due to lack of efficacy was basically comparing one version of cytarabine anthracycline to another version of cytarabine anthracycline. And so we'd really like to see new drugs start moving the needle on some of these higher risk chemotherapy resistant cancers. Now, I will say that there are some new tools that we do have. And so one of them is a drug called venetoclax, which can block the ability of the leukemia cells to survive. And that, at least in some cases, clearly has some efficacy. And so I think we're in the process of evaluating whether it can improve survival when it's incorporated with some of the higher intensity chemotherapy regimens that we use in children. So in adults, it's often used with a drug called azacitidine, particularly in patients who maybe couldn't tolerate intense chemotherapy. We're trying to see if in children you can even get better outcomes if you incorporate it with some of the higher dose cytarabine and so forth. There's also a new class of drug called menin inhibitors. So there are specific mutations. They're called MLL rearrangements or some of these what are also called NUP98 rearrangements. I don't want to get too deep into the weeds here. But these mutations are, again, sensitive to a specific class of drug that targets a protein called menin and has, at least in some of the patients I've taken care of, it's even worked as a monotherapy. It's really remarkable. It doesn't work for everybody. There are resistant mechanisms documented. But I think as we can see this moving to larger frontline therapies, I think it'll hopefully move the needle as well. And then I think, again, there's a role for immunotherapies in AML, maybe less so than in ALL because the cancer tends to be more heterogeneous. So developing a CAR for AML and having it be effective might be more difficult because it's a little bit more of a shapeshifter. But for example, we have at WashU, we have clinical trials that use a type of immune cell called an NK cell that we incorporate with bone marrow transplants. And the goal here is to see whether we can eradicate some of the higher risk leukemias by using this immunotherapy. So there's movement. It's just been slower than it was in the ALL sphere.
I wanted to ask you, with both of these types of childhood leukemia, ALL and AML, in terms of survivorship, but what is the price of success in terms of late and long-term effects?
So there are several, and it again depends somewhat on which malignancy you're treating. So with ALL, and again, one of the big advances in ALL is that we've been able to really dial back the amount of radiation that children get, because one of the places that acute lymphoblastic leukemia can relapse is in the fluid around the brain. Historically, patients with ALL had to get cranial radiation, but in the last 30 years or so, we can instead deliver some chemotherapy to the spinal fluid and basically get similar outcomes. That has a major benefit in terms of there's a difference. Let me step back and say there's a difference between radiating a 2-year-old and radiating a 20-year-old in terms of the cognitive decline that's seen. And so for a patient who has to get radiation as a 2-year-old, you will definitely see learning disabilities. And so we're trying to mitigate that as much as possible. So that's one of the consequences when we need to use it, but thankfully we don't need to use it that much. Methotrexate can also, when you're giving it intrathecally, have long-term learning disabilities, not quite as bad, but that is one of the things that we attend to is we try and follow up with neurocognitive testing and make sure that they're not falling behind in school or at least getting the support that they need. Other late effects attached to acute lymphoblastic leukemia therapy. Sometimes there's toxicities associated with the therapies and that can be lasting and have lasting effects on the heart, on the kidneys, and so forth. Fortunately, not too bad on that regimen. With AML, the one that we worry about the most is the effects of the anthracyclines on the heart. So daunorubicin, mitoxantrone, idarubicin are all drugs that get incorporated into various AML regimens, and they can severely affect heart function. And so it's something we follow and we dose adjust if necessary. It's something we are, again, attentive to if patients are going to bone marrow transplants, that we need them to have good heart function. With regards to some of the lymphoma therapies, again, sometimes radiation is involved and that carries long-term side effects, risks for secondary malignancies and so forth. And then for some of our patients, we also have to be aware of their desire to have children at a later age. I think fertility is something that we have to be more attentive to in pediatrics than, say, if you're taking care of 60 or 70-year-olds.
In adult oncology, one of the things that we face are late referrals. There's late diagnosis of breast cancer, for example, of a lot of the solid tumors and blood cancers as well. Tell me a little bit about pediatrics, your collaborations with pediatricians. How do you promote earlier referral?
We are definitely dependent on community pediatricians to recognize leukemias in a differential. I would say usually when a child presents with a leukemia in particular, it's not subtle. They are usually feeling ill. And I feel like we don't have a lot of referrals, as you're describing, in the adult sphere where it's gone unappreciated for a long period of time, which is fortunate. One thing I would caution when talking with community pediatricians, though, is to think twice before you write the steroid script.
Okay.
I think that probably the biggest source of frustration that we might get after a referral isn't a late referral as much as the patient was thought to have one thing and was treated with prednisone for a 5-day pulse or so forth, or they thought that that knee pain that they were experiencing might have been autoimmune, and so they gave them a steroid pulse. Keep leukemia in the differential, because if the patients had steroids before the diagnosis was made, that automatically increases the amount of chemotherapy that they're going to get. It will upstage them because it changes the biology of the
Wow.
leukemia. With regards to lymphomas, again, I would say that I don't worry about late referrals as much. Again, you want to not treat before you know what you're treating. And so I think awareness of the presenting signs of leukemias and lymphomas is really important, not so much because of the urgency, because I think the urgency announces itself, but rather you don't want to be doing anything that could affect our ability to treat it down the road.
Got it. Clinical trial participation. I mean, it is still a major challenge. I'll call it a problem in adult oncology. How about in pediatrics? How commonly are patients enrolled? And what are some of the barriers as you're discussing this with families?
It's an excellent question. I think historically, pediatric centers have done a much better job than adult centers in terms of
You're
getting
right.
patients on clinical trials. I think some of that stems from the fact that we have these cooperative groups that basically help establish a clinical trial as standard of care when it's available. And so it becomes much more part of our culture to want to enroll patients on these clinical trials because it also establishes a framework for treating them. As far as the barriers go, I would say right now for the frontline trials, our biggest barriers are that we're a bit of a prisoner to our own success, and we're now needing to revise trials that have closed early because they were successful. That's great news for the patients. And at the same time, it now forces us to think hard about what the next questions are going to be. Other potential barriers, I think sometimes patients are reluctant to enroll on trials, especially banking trials, where it doesn't necessarily present an obvious benefit to their child. I think it's important as a provider to reinforce the fact that the success that we're experiencing now came from the willingness of patients to enroll on trials 20 years ago or 10 years ago even. I also think that for some of the I would say early phase trials or relapse refractory trials, sometimes there are barriers associated either with a patient being too sick to travel or a family not having means to travel, or sometimes it's not even a case of means. I've had a lot of patients where they know that they might be having their child approach end of life and they just don't want to go through the process of traveling to other institutions. And so there are ways to mitigate that. Sometimes. If the limitation is means or tools for transport, we can usually work around that. There are institutions like the Leukemia Lymphoma Society that help patients travel for clinical trials and provide material support for them. If it's that they do not want to enroll on a clinical trial because they are prioritizing comfort, I think that's often something that we need to respect because it's something that's very personal to them. But you do want to make sure that they've at least had the options presented to them so that they can make an informed decision.
Thank you. Finally, I wanted to ask you about resources that you think are helpful for healthcare professionals and patients and families.
I think we could break that down into educational resources and then what I would call support resources, and whether it's financial support or social support or so forth. As far as educational resources go, a lot of hospitals, including my own hospital, do have web pages that offer education on, recognizing leukemias and lymphomas, and then offer guidance on how to refer and when to refer. They also describe the different types of leukemias and lymphomas that we treat and some of the approaches to treatment. Our leukemia program also has a separate website that talks a little bit more about the research that we're doing as well. So those resources are available, and it's not just WashU, but a number of other children's hospitals have that as well. Then societies like LLS, I think, has an excellent webpage with resources for families. If there's a new diagnosis, that's a great place to refer them to, certainly preferable to Google. I would also add that the National Cancer Institute has a very, very comprehensive description of the types of cancers that the children can get. They can also be a useful resource for looking for open clinical trials. If you go to clinicaltrials.gov, for example, every open clinical trial in cancer can be found there that's NCI supported or not. As far as support for families goes, we're fortunate that I think people recognize childhood cancer as something that we want to prioritize for philanthropy. And so LLS provides support, not just for clinical trials, but also for families seeking clinical trials. I've had ambassadors from LLS reach out and remind me that we want to be educating patients as to the resources that are available to them. Other foundations do that as well. Then there's some foundations, for example, Make-A-Wish, that it's a little different in that it supports children to go to Disney World or go take an interesting trip, and it tries to restore some element of childhood and normalcy to their life. So there are a number of resources out there to support both providers and families that are suffering with these diseases.
Thank you. I'm going to ask one final question, and it's purely just the practice of medicine. I think we talked a little bit about what day one is like when a child's at the end of life, and how do you share that with families and with children?
I'll be honest, Ken, I've been doing this for about 20 years now, and I've never really found the right words. I think there are different reasons that you have to have those discussions. And so sometimes it's because of disease progression. And I'll be honest, those are actually, in some ways, the simpler discussions to navigate because we're at the limit of our tools. And when you're having these discussions, what you want to point out is that we're not abandoning you. We're not saying there's nothing we can do. What we're saying is that we can't cure this cancer.
Yeah.
And so at that point, you're really trying to work with the family to figure out what they want next that they can find most comforting? Do they want to keep looking for clinical trials? And you want to be supportive of that if that's what they want. Do they want to go home on hospice? Would they be more comfortable having hospice care in the hospital so they don't need to experience that at home, either with their other children or remember their home as a place where their child died? I am personally very receptive to parents who maybe are not willing to cross the do not resuscitate, do not intubate threshold right away. A lot of times within the hospital, the critical care teams, for example, to their credit, will want to not do things that they consider futile. But my perspective on this is that the families are the ones that are going to need to live with these decisions for the rest of their lives, not us.
Yeah.
And so if they're not there yet, I would rather have a tube placed and have to remove it later than force somebody into a position that they're not at just yet. And it doesn't mean that we don't understand reality. I think you just have to recognize that it takes a little bit more time. And I think we have to be sort of humble as far as what those steps sometimes take. And sometimes doing some of those things, continuing to do transfusions, continuing to give antibiotics because the family feels like you're doing something, that still is a form of palliation, even though it doesn't meet the formal definition. So when I'm having these discussions, I'm trying to figure out which lane we're going to pick there. Honestly, the hardest ones are where there's something catastrophic that happened that we didn't anticipate, an infection, a stroke, something like that. And again, in those cases, you're trying to figure out where to go, but you're also trying to put the pieces back together because nobody saw it coming. And so part of what we're trying to do is, in a non-defensive way, explain how we got to this point. And those are sometimes, honestly, very hard to navigate because everything was looking fine up until event X happened.
Thank you. These are tough topics. I've been doing it 30 plus years. And yeah, the words, I've never found the perfect words. I found words that are comfortable for me and I think, lend some comfort, but always wishing that I didn't have to share those words and that I could provide more comfort. So thank you. Thank you. So again, this is Dr. Ken Miller. I want to thank everyone for listening to this informative episode and also meaningful episode. I really appreciated the discussion. I want to thank again Dr. Jeffrey McGee, who is a professor of pediatric hematology and oncology and director of the McDonald Pediatric Cancer Center at Washington University. Jeff, thanks so much for being with us.
Thank you. You're welcome.
I want to thank all of you again for listening to this informative and very meaningful episode, talking about pediatric blood cancers, also talking some about the art of medicine and the art of pediatric oncology. I want to share also that the Leukemia and Lymphoma Society has a professional development program called Staying Connected. It is a free online course for school personnel and healthcare professionals who support students who have survived or who are being treated for any type of cancer. Nurses, social workers, and educators may earn up to 6.5 continuing education credits for participating in this program. For more information, please visit www.lls.org/stayingconnected. And for a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease, treatment, financial, and support resources that are available in both English and Spanish. LLS also provides other resources for patients, survivors, and their families, and that can be found at lls.org/support. I want to encourage you to sign up for notification of future podcast episodes by subscribing at treatingbloodcancers.org. If you have suggestions for future episodes, please click the feedback button on this episode page. And we look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society, and access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.